What'd everybody do today?
Hernias.
Oh,
Full hernia day. All day.
okay. Riveting.
Yeah.
We did fine still.
Are you guys still buddy?
Mm-hmm.
Okay. Is it the whole month?
I don't know. Dr. K asked me. Yeah. I have no idea.
We just day by day.
Okay.
Yeah. I'm assuming one day I'll just pop up and I'll just be like, my name's Solo. Like, all right, it's today.
Yeah, and if they keep you paired up for like 3 months, I'd start to worry that we're a little concerned about you.
Yeah. Jack, you be my babysitter.
Like, oh, we don't want to let that guy have my home yet.
Hold my hand. I've seen that. You're always terrifying.
I can't find this on the website, so I'll email them about that. And I don't know if this is the most up-to-date version. This is just the most recent one I had in my email. But this is our ERAS protocol that I kind of mentioned earlier. So this kind of goes through, goal-directed fluid therapy. There's some sciencey things on here. And this kind of goes through the pathway. This is hard because it's not showing up like over here, so I have to lean. Oh, now it's on this computer. Okay, that's much easier. So while we're waiting for some stragglers, we'll just kind of talk about this. So these are kind of the general guidelines that when people say like, oh, we're going to do the ERAS protocol, this is kind of what they're talking about. One of the main things is that we'll do just maintenance fluid replacement. So if it's a laparoscopic procedure, we do 3 cc's per kg per hour, just kind of as our baseline infusion. And then if it's an open procedure, we do 5. And then there's like a couple different pathways on how you can do this. And basically it's kind of dependent on if you have an A-line or not. And if you do have an A-line, have you guys seen the flow track yet?
I'm not here. Yeah.
Okay. It's, kind of know what it is. It's like a more expensive A-line. That has some monitors on it. It kind of goes through basically like stroke volume, variation, things like that. So it's trying to predict volume responsiveness, basically. And then there's a different one if you don't have an A-line in, obviously. We have this graphically in here, yeah. So the way you kind of do this is for all these patients, they get a couple IVs. You kind of do the recommended ventilator settings that it's pretty commonplace in anything that you do no matter what now. And then you kind of go down this route. But basically you're looking at their baseline stroke volume. And then this is kind of before the case starts. You can give a fluid bolus and then see if it increases or if it doesn't. So if it goes up, then it's like, oh, their stroke volume was this, went up when we gave them some fluid. So clearly they're still on that responsive part of the curve. They needed a little bit of fluid. You can do it again. If it goes down, then you're like, oh, they've gone past the part where they're going to respond to that. You're kind of on here like, oh, we increased their preload. You don't really get much more out of that. So that's what it's kind of trying to judge up front. I'll get them to add this back to the website. I don't know why it's not on there. And so that's kind of the fluid management part of that. But it's just monitoring that and kind of trying to keep them in that responsive area where we're not giving them too much fluid, but we're also not like under resuscitating these people that are going to be having these surgeries that are 6-7 hours long. Most of the time they have an A-line, so this doesn't really apply most of the time. But you'll see that written on the schedule. Sometimes it'll say like ERAS, Whipple, something like that. Yeah, I don't know how to close this. Let's try this. Awesome. How many more are we waiting on? Do the VA people come over here, right? Is that?
Yeah, they usually is like a little late.
Okay, that's what I was told, is that they like show up and they're like, God, you guys started already? Okay. You guys have any major like questions or anything like that so far? Just like life related. Yeah. Okay.
fellow, but
Also, it's 50-50. So 50% of the time I'm a fellow for livers, and then 50% of the time I'm attending for other stuff in the OR. For 2 more weeks.
yeah.
Are you staying on here?
Mm-hmm.
Nice.
Is there like a special liver transplant anesthesia
Team.
like certification that you have to do, or just
No. It's kind of a newer thing. So, you know that there's like ACGME fellowships in like cardiac and chronic pain and peds and stuff like that. So there's all of those things, and now there's a lot of newer fellowships that are non-ACGME, so like regional, OB, neuroanesthesia, things like that. So transplant's the same way. It's not ACGME certified, which is why I work half the time to basically fund the ability to do a fellowship. And there's really no certification process, so it's the same with most of the non-ACGME things.
kind of nice then too, because then you don't have to test.
Yeah, you take oral boards after after you finish residency anyway, so everyone's kind of focused on that.
You get grandfathered in, and then all of the other ones landed.
They'll certify everything at some point. So
Yeah.
okay, they seem to be hogging the candy in that corner, but if you guys want to spread it around,
These guys, dude. Isn't that crazy?
Yeah.
It's like protein. It's like, they like chips. I know, it's like blowing up my hands.
all right. Well, let's get started. 'Cause the sooner we start, the sooner you guys get out of here.
Yeah.
Okay, so we'll kind of go through some PVLD type cases. We'll just kind of chat about. Did anyone talk to you guys about TAG yet? Okay. So I did want to kind of briefly go over that. So that's what the machine looks like up in there in the corner. So TAG is a whole blood test. So it's a point of care viscoelastic test. TAG and ROTAM are the two main ones. And it's looking at global clot formation like in real time. So this is really helpful when people have weird coagulation deficiencies or like liver patients, they have a very weird coagulation system. And so a lot of the times the way that their labs will look doesn't quite predict how they're going to act in real life. And so this is kind of a better way of looking at that. And so what it does is it applies a continuous rotational force to a developing clot and kind of measures how quickly the clot develops, how quickly it propagates, and then kind of the strength of it overall. And so the way that it works is what you do is you send a blue top tube, and it goes to the blood gas lab. The blood gas lab is going to run it, and basically what they do is they put some of that blood in this little cup, and there's a pin in the cup, and the pin is fixed, and the cup moves around, and it just rotates. And as it does that, clot starts to form against the pin and kind of around it, and then as it's doing that, it basically measures that clot development, and it uses a lot of fancy science to do that. And so the results that you'll get an R time, and that's basically, it stands for reaction time. It's looking at the clot formation. So it's looking at when you start the test, how quickly until something starts happening, basically. And then the K is looking at clot propagation. The angle is looking at the speed of clot formation, pretty similar. And then the MA, or maximum amplitude, is looking at the maximum clot strength. So practically, what you do, you draw some blood, draw off an A line, central line, whatever, just an IV if you can get it to draw. You put it in a blue top tube, you put a patient sticker on it, and you send it to the blood gas lab, and you fill it out on that little white sheet here. All the VA people are like, I don't know what you're talking about. And then you'll open the TAG app to look at it. And so that's in My Apps. You open that up, and then this is what it looks like on there. So you click on that. This little screen will show up. The username is TAG. The password is TAG. So you can, get into that pretty easily. The website is sometimes linked on the computers in the OR. If not, it's just myapps.uchealth.org. And then you kind of log in, and all the patients will show up, and you click on your patient, obviously. You'd be surprised how many times people never get told how to do this, and then everyone just kind of expects you guys to know how to do this. So now there's no excuse because we talked about it. And so this is what it's going to look like. So you'll send off a tag, and you can watch it in real time. It'll keep updating, so you can kind of leave this on in the background on your computer. And so, does anyone notice anything abnormal on this one?
It didn't get.
Yeah. We're on the same page. Everyone's doing that. So the R time is a little long. So it took a good amount of time before it started actually making clots. And so what that typically implies is that you need coagulation factors, basically. So FFP is kind of the main treatment for that. Do they give you guys those little things to put on your badges? Some people have them, some people don't. But it's basically like the way to cheat on this, and just it says like, oh, prolonged R, give FFP and stuff like that. And there's a little more to it than that, but in general, those rules are pretty correct. Oh damn. Okay. So on this one as well, the K and the angle are abnormal. So the K is a little bit long and the angle is a little bit short. So that's saying that it's one. Not only did it have a hard time starting to form a clot, it's also not like building on that clot very quickly. And typically, what that needs is fibrinogen and cryo. And then this one, okay. What looks like it's abnormal on there, and they put the normal ranges, right underneath. So there's a couple of things that are abnormal. I tried to find examples to show you, and there was none that were like really glaring in the last few weeks that I could find. So these aren't too bad, but yeah, I was like, it's the thing we haven't talked about yet, right? So the MA is a little bit low, and typically what that means is that their platelets are low. So it's looking, it's trying to build the clot strength up, and it can't do that because it doesn't have enough platelets, or the platelets aren't functioning enough. That can also be due to low fibrinogen as well. So that's just something to keep in mind. Okay, so that's a little bit about TAG. Just because nobody ever goes over that, and then you get in the OR and everyone says, send one, and then what did it show? And, it's helpful if someone kind of goes over that at some point. So let's talk about a couple cases. None of these are too in-depth. So let's say you have a 65-year-old lady. She's coming in for a hepatic resection for hepatocellular carcinoma. And then otherwise pretty healthy except for some cardiac stuff. She has an ischemic cardiomyopathy, so her EF is 30, and she has some high blood pressure. So what do you guys think, just in general, about the fluid management? Like, do you have any overall concerns? What are your general thoughts?
Lower threshold to transfuse because she has the coronary artery disease.
Okay.
Her EF's low, so you want to be careful of fluid.
Yeah, maybe don't flood her with a ton of fluid. That's fair. Okay. Do you think crystalloid, colloid? Do you care? You're just gonna ask your attending what they want to do?
Her albumin's probably low. I'm assuming she's got liver disease, but
You can. Some patients have pretty isolated cancer in the liver, and they don't actually develop much of an issue with their synthetic function.
What phase of surgery you're in, I guess.
Okay, that's fair. You want to avoid anything specifically? Giving her a ton of fluid, dropping her hemoglobin too low, anything else? Notice I don't have any answers up here. This is just to get us to talk about stuff. And I gave you candy, so I know you're all awake. No one's hypoglycemic. Any concerns for hepatic resection in general? The answers are up here. So in general, think about the liver, right? We have our little cartoon guy here. So you have the IVC, coming right off of there. So if you give someone a ton of fluid, or if their heart starts to have trouble pumping and they kind of get a lot of back pressure, that translates down into the liver as well. So the more congestion you get, the more it's going to congest the liver. And that's a big concern from the surgeons. So fluid management in these cases is actually pretty important. In general, like patients with heart failure, we don't want to like overload them with fluid. Hepatic resections are kind of the other big thing where I'm like, okay, we don't want to give them a ton. These are the type of people that like I go see them in pre-op, and frequently the IV will be open and kind of just running willy-nilly, and like 500's gone in already, so you go over there and you're like, okay, thank you, and you turn it off. And so that's something to keep in mind. So they typically try to run them a little bit on the drier side, and especially until they are done resecting, getting out whatever they need to do. And then the Pringle maneuver, I don't expect you to know what that is, but that's, I'll let you read about it, but they basically clamp off the blood supply to the liver, and so you can have little intermittent episodes of reduced hepatic metabolism as well, which can affect a lot of other things. I wrote his heart failure, but I said female, so you always find typos and stuff when you actually give these talks. So again, yeah, maybe don't, just go in there and like hang a bunch of bags of fluid. Their EF is 30, which is not great, but not terrible. I guess it could be worse. And so you don't want to just flood them and then have them not be able to handle that, start getting pulmonary edema from that, things like that. And then, yeah, you might have a different transfusion trigger. So I didn't say he had coronary artery disease, but I did say an ischemic cardiomyopathy, which kind of implies that. And so, maybe you would transfuse at 10 instead of 7, or, 9 instead of 7 or something like that. Again, we talked about that earlier. Like, it all depends. Every single patient's different. If you could write a algorithm for all of these things, then we aren't necessary, right? Like, if I can just write a computer program that says, send a lab, if the result is this, do this, if this, then do this, then we don't really need to be there, right? Like, every single person's different. You have to kind of think about everyone critically. Okay. Let's say this, a couple hours in the case, the surgeons are like, yeah, we've lost about 750. Think you need to transfuse? There you go. Okay. What else would you do to kind of evaluate them?
Look around.
Okay.
Are they undershooting or overshooting?
Okay.
Could do like the, what was their starting hematocrit and see if like an allowable blood loss.
Okay. Yeah. You do some math. I've never heard a surgeon overestimate their blood loss. I've never had them say it's 750, and I'm like, no, it's actually like 300. Usually it's like they're like, oh, we've lost like 500, and you're like, I'm pretty sure there's like 3 liters over there. So yeah, look around, see what's going on, see if that story fits. Do some math, calculate how much blood can they lose before we start getting worried. Let's send off an ABG, see how they're looking. You can also look at their vital signs. So this is another big, I do a lot of oral board practice whenever I have residents in my room. So this is a big thing. Like, one of the main things you need to always say is like, well, I'm going to look at the monitor and like see how they're doing, which is something we do and something you're thinking, but it's not something we say. So if they're starting to get, more tachycardic, they're starting to get a little more hypotensive, you're starting to have to give more pressor, kind of boluses of phenylephrine here and there, then that's something like, oh, maybe they're starting to actually notice that they've lost some blood. And that's, okay, let's say we send an ABG, hemoglobin's 10. Who's going to transfuse? Okay. Let's say heart rate's like 105, MAP is like 68, and you're on a little bit of phenylephrine. 0.3, we'll say. No one wants to give blood?
Also depends how much fluid I've given.
Okay.
If I'm running them dry, then maybe they're concentrating. That's not very true.
Perfect.
If I'm giving them a lot, then maybe that's their true fluid.
Yeah. So yeah, think about the case. Like, this is someone where we're not giving a ton of fluid, right? So, we're not diluting that out a lot. So you have to take that into account. All right. Let's say we're like, okay, we thought about it. No, we're not gonna transfuse. Okay, now they've lost a liter. and they started to say like, oh, we're having a lot of trouble getting control of some of these bleeders. They start to look more intense and focused. Now what do you guys think? Anybody transfuse now? Okay. Okay. Okay, I like it. What other information you guys want to know?
This is vital signs now.
Let's say you're having to go up on the phenylephrine a little more. Heart rate's kind of the same because you're going up on the neo a little bit more than that. Same ABG, pretty similar, 9.5.
I think like this morning you're saying like you bleed whole blood, so
Yeah.
it doesn't.
Okay.
I still do.
Right. Again, there's no right answer here. This is just to get you to start thinking about stuff like this. What if the hemoglobin came back at 8? Who would get blood? Okay. I probably would too. So let's say you're like, oh, we've lost about a liter, but I feel like that's going to keep going for a while. It doesn't seem like there's a quick end to this in sight. So let's go ahead and give a unit and see how they do. So you give one. Get that in, send off another ABG. Hemoglobin's still kind of the same, right around 10. And give more? Anybody?
How are the vitals?
Pretty similar.
Are they still having trouble with the bleeders?
We'll say yeah.
It's like, I forget how long it takes to like settle out when you get repeat hemoglobin split. Isn't it like an hour, 2 hours?
It can take a little while. Again, think about what you're doing other than that. Like, did you just give that? Did you give that in some fluid? The main point of this, like I said, there's no right answer. 5 different people, 5 different attendings you have will do 5 different things. A lot of anesthesia is very nuanced, and as long as you have good reasoning for what you're doing, and it's not dangerous, it's, no one's going to fault you for it. So the point is to start thinking about, like, okay, we're not just worried about the number. Like, we don't just send off a blood gas and say, oh, hemoglobin's above 10, or hemoglobin's above 7, we're not doing anything. It's to think about the case as a whole. Like, what have we done so far? How much blood have we lost? Is this a 65-year-old lady who's like 40 kilos? In which case, like, maybe a liter of blood loss is a good amount. Is she 100 kilos, 110 kilos? Like, so you have to think about stuff like that. Think about how much fluid you've given. Think about how, intense the surgeons look. If they look really worried, like, I start to get a little more worried. And so that's just stuff to keep in mind. Okay? Questions about that? These are not that difficult.
I have a question.
Yeah.
Is hemoglobin, does it come back with an EBG?
Yeah.
Okay.
At the VA, I don't know. I've never been to the new VA, so I don't know how stuff works there, but so some places will not do a full ABG, like they'll just give you a blood gas. Here, when we send off an ABG, we get lights and a hemoglobin back with it.
Oh, okay.
So you get a sodium, you get a potassium, you get a chloride, you get ionized calcium, you get hemoglobin. So it's quite nice. Okay, that one wasn't too bad. So let's talk about a different case. Let's say you have this 30-year-old guy on trauma activation. You guys aren't taking call yet, are you? Okay. Let's say it's your first day on call. And we have a trauma pager here. So they hand you the pager, and like 30 minutes later it goes off. And it's like, oh, this guy has a gunshot wound to the abdomen, we're coming upstairs. You don't know anything about him. They intubated him in the field. He has 2 14s that EMTs place. They're just running in saline. And they said, we ordered MTP. We'll meet you upstairs. Massive transfusion protocol. Guys, this morning we talked about give me my Snickers back. Alright, so what do you think? Like, you call your attending and they say, okay, go set the room up. What do they tell you? What are you gonna set up? What are you gonna do?
Belmont.
Okay. What else?
Warmer.
Okay.
Possibly.
Okay. You gonna get some blood? Okay. What else can you use besides a Belmont?
Pressure bag.
Okay. Does everyone know what a Belmont is? I hear you explaining it. Okay. So a Belmont is a very, very rapid infusion device. And so it is a big cylinder. You put products in it, blood products, fluid, and it infuses them. It'll infuse them up to 500 cc's a minute. And so we use them in every liver transplant that we do. They use them in some cardiac cases, and we use them in a good amount of traumas. There's another rapid infusion device that gets used more commonly. So I don't know what it's called. Yeah. So level 1 is kind of the same thing. It's like the older version. Like that's been around for a long time. And so level 1's same thing. It's a rapid infusion device. You're going to hang blood products on there or fluid. And it has a pressure thing. So you can put it in there, turn it on. It's going to infuse under pressure. With the Belmont, you do have to be careful what you infuse it through. So it's not designed to go through IVs. It needs to go through either a cordis introducer or what we call a RIC, rapid infusion catheter. You'll see people hook them up to peripheral IVs, but you're really not supposed to do that. Because you're infusing fluid under so much pressure so quickly, if it infiltrates and you don't notice, it can blow up that arm pretty quickly. So something to keep in mind. So okay, yeah, you're getting the room set up, you call the blood bank, you say, hey, I heard this guy's on the massive transfusion protocol, can we get a cooler? They're meeting us up here. Get some albumin out of the Pyxis. Make sure you have plenty of crystalloid hanging. Having plenty of IV tubing set up, so that's something that often doesn't get thought of. The ED, sometimes we'll have some stuff running in, but if you're going to place more lines, you're going to want stuff to, connect to that, so you have more access to give drugs, give things, give blood. And then let's say we get in the OR. What do you guys want to send off?
Lactic acid.
Sure. There you go. Yeah, so we're like, okay, let's see what's going on. Like, a lot of times, some of their lab values are out of date. They might have been in the ED for a little bit before they came up, or maybe they just, kind of flew through the ED and they said, no, let's just go upstairs. So you might not always have the most up-to-date information. So one of the first things we do in a lot of cases like this is we get in the room and someone just draws a bunch of labs. Typically, we'll send off an ABG. It does not include a lactate, so you can order that separately if you want to. And then we send off some coags, maybe a CVC, see what's going on.
Do ABGs here come with base access?
Mm-hmm.
I have a question about that last one. So, I guess I didn't work with a lot of trauma doing internal medicine, but like a lot of our massive bleeders, we never gave colloid because there's a lot of studies that show that crystalloid versus colloid, there's no major difference, and so.
No, so we kind of talked about that this morning. So there's you'll find people that are very passionate about both sides of that argument. I've never really seen a good study either way. A lot of people kind of are of the thought process, like, everyone starts with crystalloid for almost anything that you do. And then after you've given someone like 5 liters of crystalloid, obviously, you might want to switch to something else, whether it be blood or albumin or something like that. Burns are the main ones that they kind of just crystalloid for a while. But we give a fair amount of albumin in the OR. In traumas, we do that fairly frequently, but if it's actually like a really bad bleeding patient, we're giving so much blood products that you don't really need much other fluid. Okay. So then what makes you determine, what blood products you're going to give? If they come in there and they're bleeding and they're bleeding, are you just going to give stuff right off the bat? Are you going to wait for your lab results? Are you going to give red cells and FFP?
1-1-1 ratio.
Okay. What does that mean?
So that means you do, for how you transfuse is 1 unit of blood, 1 unit of FFP, and then the platelets it's like 1 to 6 because that's how the ratios are for the super packed units.
So 1 unit of platelets is usually a 6-pack of platelets. And so that's why our MTP coolers come with 5 and 5, and then they give you a platelet every other one. So that's based on a lot of trauma research and military research. Are you just going to follow that? Like, we get in the OR and you're like, nope, don't need any labs. I know what to do. We got a ratio here. Are you gonna look at the labs? How are you gonna decide?
It depends. Like again, like if I'm seeing this student sanguinate in front of me, I'm just gonna start transfusing. And there's also like the criteria, like the ABC criteria, where it's like if they have 2 points more, or at least 2 points, it's like their first blood pressure is like more than or less than 90, or forgot the other criteria, but you use that criteria.
Heart rate's one of them as well.
Okay.
But then if you meet that criteria, you just start transfusing right away. And then after that, you like be concerned with all the coagulopathies, you'd send a tag and then guide your therapy from there.
Okay. Let's say it's the middle of the night. Our lab techs can't always like get over here and get the tag running. Like that's gonna take 15 minutes or so. You give some FFP. How are you gonna decide? Are you just gonna ask and be like, "What do I do?" Again, there's no right answer here. I just want you guys to think about this. In reality, your attending will be in the room, will be telling you what to do. But one of the whole points of doing residency is to take what people are telling you the whole time and start to think about this on your own so that you can start to think about, what would I do? If I'm the only person here, what would I do in this situation? So yeah, that's something everybody had good suggestions. So it depends on a lot of things, right? Like it depends on how much they're bleeding when they get up there. It depends on what their vital signs are. If their pressure is 60/30 and we're trying to treat that and they're still bleeding, I'm just going to put whatever we have in the patient to try to increase their volume, like to help you out. Platelets, you can send a tag, you can send a platelet value on a CBC, or you can look at how much they've gotten already. That's another thing that a lot of people don't think about is if these people have been, kind of resuscitated in the field and then resuscitated in the ED, and they come to us, or patients that are in the ICU and bleeding for a while, like sometimes they're bleeding all day, and then they come down to the OR, and you say, hey, what did you give already today? And they say, oh, we've given 12 red cells and 1 FFP. You're like, okay, I feel like they might need a little more other stuff than just the red cells. Kind of gives you a clue. And then what IV fluids are you going to hang on all your bags when you're setting up all your tubing? Here? Okay, perfect. So like we talked about earlier, like if someone's dying in front of me and I like need to get blood into them and LR is hanging, like yes, you're going to give them blood, but no, you're not supposed to do that. If you give something quickly enough, like, obviously you can be hanging LR on this IV going into this arm. You're giving blood products over here. They're all mixing together, fairly quickly. But no, you're not supposed to transfuse with LR. So plasma light or saline. And then when do you stop transfusing?
When they get control of bleeding, would be at least a good time to reassess what you're doing.
Okay.
A little bit of like 10.
Okay. Okay. All right. Again, I don't have an answer in my head. I just want you guys to think about this.
Well, my attendant yells at me.
When the pathology lab calls you that they're out of blood.
You joke about that. We almost ran out of platelets the other day. Okay, so let's say get into the OR. They open up their belly. They've gotten 10 red, 10 FFP, 1 platelet. You're like, okay, they got control of everything. They're starting to close everything up. You're like, I'm having a harder time, ventilating this patient. Their sats are going down. Just kind of slowly. Like, maybe they were 100, and they're like 97. And then over the past like 30, 45 minutes, now they're like 90. Peak airway pressures are a little bit higher than before. What do you think's going on? Okay. The surgeon looks up at you and he's like, hey, we're almost done. You gonna wake him up? I'm like, okay. We don't really know what's going on with the lungs, right? So maybe we say, okay, let's leave this guy intubated. let's see what's going on. Go up to the ICU, get a chest x-ray. What do you think? Normal or abnormal? Okay. Pass. Alright, so what could be going on? You guys have said it already.
A taco or trauma.
Okay. I agree. Those would be my two main concerns. You know, they gave them a lot of blood products. Kind of look at, you know, other things going on, like whether they're having, you know, other trouble with their blood pressure. If you have other lines in, is their CVP up? Things like that. But yeah, definitely, you know, something's going on. Gave him a lot of blood products. He's having some sort of reaction to that. Whether it's trolley or taco, you kind of have to see what his heart pressures look like to fully determine that. All right, questions about that? Okay. The main point of this is just to get you guys to start thinking about stuff like this. Like, it's, you know, you're learning a whole lot of new stuff right now, and everyone's just kind of telling you what to do. But it's important to think about why you're doing each of those things that you're doing, so that you understand them. If you don't understand them, ask. If someone says, hey, let's give FFP now, say, hey, why are we giving FFP, just so I understand? You know, because sometimes we assume everyone knows something that they may not know, and that's fine. You're here to learn. That's the whole point of this. Okay. VA people, I apologize, but this will be relevant to you eventually. So I also just put some stuff in here for practical purposes. Has anyone ordered blood? Okay. So there's two order sets. There's like a ED and inpatient order set or something like that. If you want to order it ahead of time, you can also order it from our preoperative anesthesia order set. So when you order the pre-op order set for any patient, there's a spot on there for like type and screen, and you can cross them for some red cells. In the OR, if you need blood, what else? There's one called UCH intra-op transfusion that you can favorite on your Epic. And so that's how you would order that. You can open that. It gives you the option to type and screen, view the type and screen. If you're not sure if they have one, you can order red cells, FFP, cryo, platelets. You can order the massive transfusion protocol on that. You can stop the massive transfusion protocol on that. So the blood bank gets a little grumpy if we put someone on massive transfusion and then they say, hey, you know, you guys haven't asked for a cooler of blood in the last 4 hours. Like, are we good now? Did you give up? Like, what happened? So it's important that once you do stop transfusing and you think that they're out of the woods from that, to call the blood bank and just say, hey, we're going to stop the massive transfusion protocol now. Because otherwise they have techs in there that are making these coolers up so that they're ready to go when you call for it. And so it's nice to say, oh, don't worry about that anymore. And they get a little grumpy if you're like, oh, I forgot to call you, sorry. But usually they figure it out because you kind of just stop asking for stuff. The blood bank phone number is 84444. And so I think it's in most of the phone books, but the phone books on your phones have a way of like updating randomly, and then you lose some numbers and things like that. So a lot of people will write like important numbers on their phone, like pharmacy, the blood gas number, blood bank number, and then just kind of tape it to the back of your phone. It's also on the little online phone card. And then what if your attending says, hey, I want you to give this person Plasmolite? That's not in all the rooms. So it's in some of them. It's in all the heart rooms. It's in all the liver rooms. Most rooms have one thing of Plasmolite down where all the IV fluid is. But if you don't see any, the anesthesia tech assigned to your room is the person you call. So they have it all, and you can call them and say, oh, we're going to need a lot of Plasmolite. Usually tell them like how much you think you'll need, because otherwise if you just call and say, hey, I need some Plasmolite, they usually just bring you one. And so sometimes you're like, no, I need like 8 of these. So just give them a call if you need that, but LR is usually in most of the rooms standardly. And then there's usually some normal saline. I think there's maybe a liter bag of that. There's some 500 liter bags or 500 cc bags of that. and then little bags of it as well. And then albumin is in the Pyxis. Everyone's seen the Pyxis in each center well. So that's where you get that from. You can also just go up to the pharmacy window and ask for some. And then if you're in the OR and you need some, the circulating nurse is able to go get that for you. They're also able to go get you like warm LR, which is in the little warmers in the center pods as well. So you obviously can't leave the room. Well, I guess you're buddy, so one of you could. But later on, when we trust you and you're on your own, then you just tell them like, hey, would you grab me, a 500 cc bottle of albumin, and they'll go get it for you. That's pretty much that. This is the transfusion order set. It's like very fuzzy on this screen. I don't know if you guys can see it very well. But you can order everything on there. The important thing on this transfusions order set is because it's designed for being used in the OR, it defaults everything to stat. So otherwise you have to manually change that. Or it'll just say routine, and they're like, yeah, we'll have blood in a while. So it's important, they can't tell very easily that you're asking for it for the OR, but if you use this, it should show up that way. And then, where'd the mouse go? You can also put a keep ahead order in. So if you're like, okay, we got some red cells in here, or we got some FFP in here, we may need more, and we may need it quickly. You can have them keep a few ahead of whatever you asked for, and that would be available if you needed it quickly as well. Someone always answers the blood bank phone number, so you can always call and ask them, like, hey, is there blood available for this patient? Or what do I need to do this? Did I order this correctly? They're always there 24 hours a day. They always answer. And it's hard to tell sometimes, like patients that have been in the OR, and then they're in the ICU, and then they come back to the OR, and then they're in the ICU, and you go into results review, and it's like RBCs issued, return, transfuse, and you're like trying to figure out what's going on. And I'm like, okay, do they still have products available, like waiting in the blood bank? Do we need to order more? You can call the blood bank, give them the MRN, and just say, hey, what's available for this person? Do we need to order more products? Stuff like that. And I do that all the time. And then the biggest piece of advice I can possibly give you is if you're doubting anything, just call. Just call and ask. That's the best thing I can tell anyone. Like, no one's ever going to get mad at you for asking a question. Like, you're here to learn. You just started. That's what we're here for, is to teach these things. But sometimes, like I said, people will think like, oh, you know how to order a tag. And some people get scared and they're like, no, I've never done that, and I don't want to ask because then you'll think I'm stupid. And like, we won't. It's fine. And I would much rather have someone call me and say, hey, I've never ordered a tag before. Can we go through it? I'm like, yes, absolutely. Because otherwise I might just assume that you already know how to do that. And then, you keep going further and further down the path, and then this never gets addressed. So, like, literally, call. If you have any questions at all, just call. No one's going to get mad at you. We're here to teach you guys. I got a picture of the new phone instead of our old ones. So I think you guys all have the new ones, right? No? Some of you have the old ones? Okay, the old ones are better. The new ones mess up a lot. This is my beagle sleeping in several different positions. It's very strange.
This floppy here.
Yeah, he's creepy. He's creepy.
Yeah.
I'm not joking, he was asleep like that. He like stretched and then he just went, oh. And then like 30 minutes later he woke up. Yeah, and then I think he doesn't really have like a spine that functions very well. He sits like a bird, like completely turned around. Alright, questions, guys? Okay. Alright, that's it.
Yeah.
Thank you.